Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at Bill Gatton's ETSU College of Pharmacy, and today is the first of a three-part mini-series on different training pathways in oncology. And I am joined by the future junior and senior senator from the state of Florida, Brooke Adams and Sarah Wheeler, and we are talking about PGY2 training as a pathway to a career in oncology pharmacy. So, Sarah, let's start with you. Tell us your current position and your PGY1, PGY2 pathway.
Yes, thank you for that introduction, John. So I am currently a clinical pharmacist practitioner at North Florida South Georgia VA in Gainesville, Florida. I've been here for a little more than 2 years. Prior to that, I was a clinical pharmacy specialist in hematology oncology at UF Health Shands, also in Gainesville, Florida. I do primarily solid tumors with some dabbling into hematologic malignancies as well. My PGY1 and PGY2 training was completed at Emory University Hospital in Atlanta, Georgia.
Thank you, Sarah. And you worked with Brooke for quite a while. That's the whole reason, really, to do this podcast, because you guys don't work together anymore as work besties, to get you back in the same Zoom room. So, Brooke, I know your training history, but go ahead and enlighten our listeners.
You don't say. So I'm Brooke Adams. I am currently a clinical pharmacy specialist at the Orlando Health Cancer Institute in sunny Orlando, Florida. And I, in my previous life, worked with Sarah at UF Health Shands, and I was her heme BMT counterpart. And we worked there for 6 or 7 years together. Before I did that, I did my PGY1 and PGY2 training at Indiana University Health in Indianapolis, Indiana. And before that, I was actually Dr. Bazar's student.
That's right. I remember when you interviewed, because we used to, faculty would sit in on lunches with interviewees, and you very clearly early on wanted to do oncology. That was, you
I
came to
did.
pharm school wanting to do oncology. Sarah, when did you know you wanted to do oncology pharmacy?
I have a little bit of a different background than Brooke does from that standpoint. My dad was diagnosed with stage 4 colon cancer when I was the summer before my sophomore year in high school. And I didn't even know what being a pharmacist really entailed because prior to that, we occasionally took an antibiotic to Eckerd because it was Eckerd back then. And that was pretty much it. So I went through school, got into undergrad, trying to figure out what it was that I might want to do. And really throughout my dad's journey, I kind of started to realize how cool drugs were, how cool it was that if you had a pain, you took an ibuprofen, that your pain went away, and really kind of started to look into what being a pharmacist would be. So once I got into pharmacy school, they really didn't talk too much about oncology kind of pathways. At least I don't remember them doing that. So I actually thought about doing it whenever I was in my rotation. So in my first rotation in solid organ transplant, I absolutely loved it. It was at an academic medical center, and all of the learning opportunities hit me in my face, and I loved it. And I was like, oh, if I can do this in oncology, I'm golden, because I felt like I had the heart and understanding for what it would be like to take care of oncology patients, because at this point my dad had already died. So I understood what that walk looked like, what that journey looked like, what it was like for people to lose their hair, to throw up, like that kind of thing wasn't going to bother me. And if I could help them walk through their journey like people did for us, I thought that was something that I would really enjoy, both professionally learning all about these really cool drugs, but then also personally as well. So I think it was really my first rotation when I learned I could do it in onc that I kind of went that direction.
First rotation APPE or first rotation PGY1?
APPE,
APPE.
yeah,
So you were
APPE.
P4. You weren't thinking oncology from the get-go like Brooke and I were, because I was thinking that.
I didn't know it was an option.
Okay.
So in my like little
Yeah.
blue collar world, like it wasn't, nobody in my family is medical at all. Like my parents aren't, my daddy was a phosphate dragline mechanic. My mom was a teacher. It wasn't, I just didn't really know what was out there. I think I would have been had I known it was out there. I just didn't.
Yeah. Well, so there's, the clearest and most direct path, but by no means the only path to being an oncology pharmacist is the PGY1 then PGY2 path. And so, Brooke, to test your knowledge of Indianapolis, do you remember how downtown Indianapolis is laid out?
I sure do. I was connected by a people mover.
So you've got Monument Circle, which is right in the middle of the city, and the north-south running street is Meridian. And the whole
Hmm.
downtown area is kind of outlined by four streets that make a perfect square. And on the north, that is bounded by North Street and East Street and South Street and West Street. So it is very much a planned city because they had the time to think about what is this city, what do we want to look like when it grows up? You go to like north end of Boston, it's not like that. You go to the Peninsula of Charleston, it's not like that because the city grew as people moved in. It wasn't necessarily planned. And so PGY2 is kind of that way, especially in Brooke and I's approach, is we were thinking that. And I remember as a student, I was telling Brooke, if you want to do this, here are some projects you can do and things to help make yourself an attractive candidate for PGY1, PGY2 in oncology. Now, there are lots of other ways to do this. And so this will be a good time to maybe shout out some of those and to say that this miniseries is sponsored by Kelly Carlstrom's ELO Collaborative. Enjoy Learning Oncology is what ELO stands for. And it's designed for pharmacists working in oncology, especially those who might be listeners of this podcast regularly, who just kind of fell into this work. Maybe they were like Sarah and they didn't know that this was a field, but they had a personal connection or story that inspired them where they knew they had the heart to do this, but didn't necessarily have the clinical training to do this. So the ELO Collaborative is really for those folks who maybe didn't have residency training, but do want to work in oncology, which is an overwhelming field to keep up with. And so it's a comprehensive curriculum with 24 courses covering all major cancers, updated regularly with wonderful content experts. I participated in the course as a content expert on drug interactions and clinical trial evaluation. There are live monthly phone calls or Zooms. It's a supportive community, and there are quarterly professional development workshops. Um, so thank you to Kelly for sponsoring this. Back to talking about PGY2 training. So Sarah, what was the most important lesson or lessons that you got from your PGY2 that maybe you wouldn't have received without that PGY2 training?
That's a good question, John. I'm not 100% sure. I'll tell you a few things that I think were super beneficial for me. One of them, now in my PGY2, so if I wouldn't have done a PGY2, I would have been a pharmacist practicing somewhere. So maybe the same thing would have happened, but I'm not sure that it would have. My first clinical rotation in my PGY2, Trevor McKibben, I think you know him, he was my preceptor at the time, and I would be in clinic, in med-onc clinic, and I would have a question that would come up, and I would always run to him, run by my answer to him, and then I would run back. And then one day he disappeared. He was nowhere to be found. He wasn't in his office. He wasn't answering his phone. He wasn't answering his email. And I had to answer questions by myself because I didn't have my safety net there to run things by. And so I think it was a really, really good moment for me to really learn how to trust myself, to trust my training, to trust my ability to critically evaluate things, to critically evaluate evidence, to work up patients, to do assessments, and to come up with an appropriate way of managing a patient care issue or an appropriate way of answering a question. And it really helped to instill some confidence in me that otherwise I don't think I would have had. So if I would have just gone on to be a practicing pharmacist after my PGY1, I'm not sure I would have had that same formative experience and that same knowledge of knowing that somebody had faith in me and that I should have faith in myself.
Yeah, so you're talking about that professional development of getting confidence in yourself. And it sounds like you probably had a lot of experience answering those types of questions and you'd get the retro or the prospective okay from your preceptor. And then you kind of move to, okay, I've got to answer these now. And then I'm going to see if they're right afterwards. And they probably were. And that gave you a lot of confidence to be able to continue to do that. Brooke, what would you say was the biggest lesson or one of the biggest lessons that you learned during your PGY2?
One of the biggest lessons that I learned is how much everything is all about the patient. So, when we are students, when we are taught, we think black and white. We think we treat numbers, right? Phosphorus is high, we give a phos binder, we lower the phosphorus. But how does that actually translate to the patient? And so, if I hadn't done residency, became a practicing pharmacist right away, which would most likely be behind a computer verifying orders, I would have never gotten that direct patient care with the team as an interdisciplinary team member working directly with that patient and seeing how my interventions truly reflected. And I believe that's made me the compassionate pharmacist that I am today.
Yeah, I think probably my biggest lesson is learning that nuance of selecting drug therapy in those situations where it's not clear. And that's one thing, Sarah, before you got on, Brooke and I were talking shop a little bit about myeloma, and the quads are preferred category one now in NCCN, and if you're not, if you haven't been in that room or on rounds with a physician going through a shared decision making with a patient, you're just going to think everyone gets DARA VRD. And that's not everyone should get that. But the guidelines say that's category one preferred. So you kind of are going to not have that nuance unless you see that in effort or in practice. And that's the biggest lesson I got from PGY2 that's helped me is seeing how physicians think. And, we're thinking about drugs all the time, and they're thinking about everything else about, oh, this patient lives like 2 hours away, though. And they're thinking about the fact that the patient's wife is sick. And so you're going through all that kind of stuff, and it is really hard. As it's much better care if you get to know your patients and the care that you can provide for them. And if you are stuck behind a desk or your task and metric to death and how many orders you verify and stuff like that, it's hard to get to know your patients to see that. And so PGY2 really gives you that time to see how that is done. I'll give you a quick story of something else I learned because a lot of times these PGY2s are at academic medical centers. These are really good physicians, oftentimes, really talented, really bright folks. And so we had a patient that had, every time this patient got inhaled pentamidine, they had profound thrombocytopenia. And we're like, this should not happen with this. And this happened multiple times. And finally, this physician sent, I think it was 2C19 or 2C9. He sent a pharmacogenetic test in like the late 2000s for this. And it came back that this patient was a poor metabolizer for this. And that was the reason, just a little bit of exposure systemically of inhaled butanediene caused that severe thrombocytopenia. And I never would have thought, as a pharmacist, I'm ashamed to admit, I never would have thought about that until seeing him do that. And I have pulled that card successfully multiple times in my career from learning that from a physician. Now, PGY2 is hard, right? Uh, Brooke, was PGY2 harder, easier? And I don't mean like the science necessarily, but all of it than your PGY1.
It's different. So instead of doing warfarin clinic, which honestly, that is not my cup of tea by any means. PGY-1 was a little bit more difficult to me because I didn't have the passion and the drive, and you kind of had to force yourself to learn these things. Whereas when I got to PGY-2, I knew this was the rest of my life. And so no matter how much harder it was or how much time it took me to do things, it was more enjoyable and was where I wanted to be. So PGY2 I knew was exactly where I wanted to be and the pharmacist that I wanted to be. So was it harder? Not to me, but it probably was harder from a time commitment perspective, all the things you were managing, everything that you were tackling, the emotions that oncology brings to you. If you're not prepared for it or you haven't gone through it before. So I'm lucky I've never had a family member ever have cancer. And I don't even know what that would be like Sarah does. But the emotions that it triggered for me when I got connected with a patient and their family member, and they became a part of my personal family, and I became a part of theirs, especially with BMT that I work in. That's what made it harder.
Yeah. Sarah, what about you? PGY2 versus PGY1?
I also felt like PGY2 was easier, but I think it's for a couple of reasons. So one for me, when you've already gone through a PGY1, you understand what a residency is like. So you have a better understanding of how to juggle everything. You have a better understanding of how to manage your longitudinal projects, how to manage your rotations, how to do this, how to do that. There's going to be days that suck, but you're going to get through it. You've already done it once. You know you can do it again. So all of those kind of pressures of sort of the unknown and like management of residency and being a resident, you've already figured out. So that part I felt like was easier. And then I loved oncology. So that part I absolutely enjoyed too, because I was also like Brooke, there were some rotations as a PGY1 that I really just didn't care about. That I did them because I had to, because they were required. But then when you get to PGY2 and every rotation is in something that you really enjoy and that you really like, and it's something that you're so excited to go read about and learn about. And because I think it's also back to your question about something I thought that was really beneficial from PGY2, I think is also understanding the why. There's so many different whys that I think that we really need to understand. Like back to your story with the pentamidine, like why did this happen, or why do we renally dose adjust, or what's the worst thing that's going to happen if somebody accumulates, or why is this particular regimen better for another patient, or why is this patient acting this way, XYZ. I think exposure, like you guys said, was also really beneficial for me submitting a little bit more of that clinical acumen that maybe I didn't always understand, and then also pulling those different patient-specific pieces in that they don't really teach you about in school. So I think as in PGY2, it was easier because it was stuff that I liked. I knew how to be a resident, and then I got to really start putting all of these pieces together and develop my own practice and the kind of pharmacist I wanted to be, and that was fun.
Yeah, I think the why is incredibly important to understand why this is the first line regimen in the guidelines. Because as clinical oncology pharmacy specialists, when physicians have questions for us, it's like they can look at the guidelines. It's usually going to be in those complicated scenarios where like this doesn't fit. This falls somewhere in a gray zone, and you have to have been pushed to kind of look for the why, not just the what. And you do get that in your PGY2 training. Now, all three of us stayed at the same place for our PGY2 that we did our PGY1. Um, and so you get, I have the same answer that you both had. It was easier for me because it was learning was not a chore. It didn't seem like work. And read about and learn about oncology just never felt like work to me, which is why I do what I do, because I do really enjoy learning new stuff about cancer and cancer treatment. But PGY2 or PGY1 was, I think a struggle for everyone who goes through that. So let's say you're a PGY1 resident and you're at that mid-year and you're thinking, all right, I think if I do, I'm a little bit burned out. I don't know what the rest of the next 6 months are going to look like. Um, if I do a PGY2, it's probably going to be oncology, but I don't really know if I want to do that because I see on the job boards that they'll hire pharmacists if they're interested in oncology and they've done a PGY1. So what would your advice be to someone in that setting, Brooke, where they're like, all right, I'm doing a PGY1. I kind of don't know if I'm going to see the value of a PGY2 versus just going and entering the oncology pharmacy workforce after PGY1.
I think both paths are right, depending on who you are. I would not trade my training for the world. I would do a PGY2 in a heartbeat all over again because I think what I got out of it is something that I would never be able to get if I had done a PGY1 and then went on the job. I think it is much more difficult to do a PGY1 and then go on the job and try to learn because you're trying to do your job and learn at the same time. So it's not going to be a 40-hour work week that you think you're signing up for. You have to put in that work and that dedication after hours. And you're not going to be able to get to round with the team necessarily in the beginning and get all of those things that you get out of PGY2, and you're not going to have necessarily a PGY2 trained preceptor to help you either. So I think it would be a much more difficult route that is absolutely doable, especially with people like Kelly that are out there that are pushing these people to be able to do this without doing a PGY2.
Yeah.
If there weren't people like Kelly that were doing this out there and giving that option, then I definitely think the PGY2 route is 100% the way to go if you are just heart set on doing oncology and you're wanting to be a specialist.
Yeah. Well, I think sometimes too, where you are in life, you might not be able to do a PGY2. Like you
Absolutely.
might be burned out. And I think if you're, thinking about, all right, I'm gonna have some extra reading I need to do every night. And if you see that as exciting, yeah, PGY2 makes sense. If you see that as a burden, then maybe you don't do that. But down the road, maybe the ELO program becomes a good option for you when you are interested in learning more because you can't force it if you're not wanting it, probably. Um, I've got a little transition here, but before I do that, Sarah Brooke, anything else that you would say, this is really what we haven't said. This is a big benefit of PGY2. There's lots of networking opportunities. You get to know these preceptors that are well known in pharmacy and stuff like that. So, what are the other benefits of PGY2 besides the training?
Absolutely. It's not always direct patient care that is the benefit of PGY2. There's also that research that you get to do. So you get to do and own a research project. You get to figure out how to submit things through the IRB. You get to write a manuscript and potentially get your first publication if you didn't do that while you were a student or a PGY1. You get to figure out how to do an MUE, you do monographs, and you have someone kind of to handhold you along the way. But networking is huge. Getting involved in HOPA early on was something that I found very, very valuable. And all PGY2s send you to HOPA. So you get to go to your first big meeting and have it paid for. And you get to go and immerse yourself into this huge oncology pharmacy family. And that is one thing that I truly remember being an amazing experience for me. And I haven't missed a HOPA annual conference since. So I'm not sure if I didn't do that PGY2, if I would be who I am today.
Yeah. What other
I think it's
benefits?
also, oh, sorry, go ahead, John.
No, no, you know the question.
I I think there's also some like practice management things that are helpful as well because as much as we all love doing direct patient care, there's a lot of admin things that end up happening that you have to manage as well. So whether that be formulary management, cost savings, if that's dealing with different office politics, so to speak, whatever, there's a lot of those things that are going to be present in any job. And so I think that was also an advantage of PGY2 is not only do you get to learn from all of these other people and their experiences, you also get to learn the nuance and things that aren't written down. I think decitabine still has the wrong dosing in the package insert. So there's like things that you legitimately learn with people who know these things that you're otherwise not going to know. And then they help you learn how to manage your practice. So if that's how to better organize patient care, if that's how to do time management, if it's how to send a professional email, if it's, how to know which balls to kind of let bounce for a minute. I think it is another way to help you do that because whenever you go on to your own practice, especially if you're going from PGY1 straight into being a specialist, I found it helpful that I had other people to kind of model for me how they did the transition. You have people that help you transition from PGY1 to PGY2 and then PGY2 to being a practitioner and how you manage the emails and you manage this and you manage that. I also found that helpful because once I became a specialist on my own and had my own service and my own responsibilities and my own everything, my preceptors didn't really shelter me too much from that. So I was kind of used to managing all of those balls because I think sometimes in training it can be just focused on direct patient care and your longitudinal projects and rotations and responsibilities that the other stuff that like all of our preceptors have to do, we
Mhm.
didn't get exposure to. So I liked getting exposure to that. So I felt like I was more prepared for when I actually had all aspects of the job as a specialist.
Yeah, let me transition a little bit because you two both precept PGY2 residents, um, and have worked in PGY2 programs as preceptors. I have not. In our center, we've got PGY1 programs, but I spend more time with our medical oncology fellows than I do training pharmacy residents for careers in oncology. When I finished residency in '09, most of what I did at MUSC was malignant heme and BMT. And I haven't done it since. And my position here is very much solid tumor, very much medical oncology, and a decent amount of malignant heme, but not transplant, and not a lot of young, and no AYA, ALLs. Um, Things have changed a lot in oncology since 2009, and the PGY2 scaffold, I think, is still it's still a year. Probably still are doing those weekly topic discussions on anthracyclines and acute leukemias, but there are more drugs. There's so much more to know. So I'm curious how you have seen, the training of PGY2 residents evolve in the last decade that you guys have come out to practice. How much has, if it has shifted from this is what you need to know to this is how you need to teach yourself, this is how you need to stay current, and this is how you need to continue to keep growing. Um, Brooke, you're RPD, right?
RPC.
RPC. Okay. So how has that changed for you all with your residents?
Yeah, so it's funny that you bring that up. We just went through ASHP reaccreditation last week. And we're talking about the new standards that are going to be coming out for PGY2 programs in a year or so. And so when you look at the appendix of all of the topics, the appendixes continue to get bigger and bigger and bigger. So we've been having a discussion of how do we get everything in these rotations. They're trying to do direct patient care. You're trying to staff, you're trying to do your research project, your MUE, your journal clubs, in addition to all of these topics. So we've ended up doing some things longitudinally to try to break them up. We've done a lot of topics like your meat and potato topics during orientation instead of waiting to get to rotation. So doing CINV, tumor lysis syndrome, febrile neutropenia during orientation while they're learning to staff. But it's continuing to evolve, and the topics are getting bigger and bigger and bigger and more and more and more that we've started those old historical drugs that we don't use anymore. We started letting those fall off. Um, Even though they're still important to know, it's just we don't use them anymore. And we have the bispecific era, the CAR T era, the TILS era, all of these things that we didn't have when honestly I was a resident, which was 10 years ago.
Yeah. Sarah, what about you?
Yeah, I agree. It was it's really interesting the way that things have changed over the years. This is not really related, but sort of related. I was talking to a colleague today about IV Velcade, and she was like, IV Velcade? She didn't know. Like
Yeah.
it became a practitioner, after that part of it. And so I think it is really interesting about how do you balance your historical content, Brooke, with like getting rid of some of those older drugs because there is so much to cover. There's new medications that are getting approved every day. There's new novel mechanisms that are getting approved. There's, different indications that are coming out. So I really think it's just trying to help people make sure they know what they don't know, being aware of what you don't know, and knowing where to look things up when you don't know, what resources are available for you, kind of getting them plugged in with, HOPA, with different organizations, with listservs, with reputable sources to try to help keep up with, everything that is new that's coming out, and using the internet, social media, the good parts of it at least, to try to help you keep up with it, because otherwise it can be really overwhelming, and to get everything covered and everything that you need, it's a lot. And some stuff is definitely more important than others. So trying to prioritize, the things you see every day versus the things that you may only see once in a blue moon. Okay, hey, this is important, but it doesn't happen very often. This is where you would find information on it. We're going to focus on, the patient in front of you today that has this instead.
Yeah. I think when I was a resident, I remember Philip Hall telling me, all right, so here's the backstory behind this. And I'd kind of not visibly roll my eyes, but in my head, I would roll my eyes like, I don't need to know this. And now I really love that historical context. And it's really helpful. Like, you might not need to know in day-to-day practice about the history of IV Velcade causing more neuropathy than sub-Q. But there might be some new drug in the next 6 months where that might be pertinent to think about the peak concentration, how that could relate to toxicity in some way. And so that historical perspective is really helpful because there are a lot of patterns that repeat themselves in oncology. And so PGY2s today are harder than they were last year and harder than they were the year before because there is more to know, and it hopefully programs are resetting expectations for what is achievable in that time, because you are going to need to say, listen, by the end of your PGY2 year, you're not going to be able to manage all these cancers independently, probably, and everything. Like that's the goal, but you're not going to be able to manage a full patient load doing that. It's going to take some time, especially if you go into a very niche discipline like breast cancer or GI clinic or something like that to get up to speed. And you probably need to start planning after your PGY2 for what is going to be my professional development. Is it going to be HOPA going every year? Is it going to be something like the ELO? Because you don't have to, I mean, people who've done PGY2 can join that as well. Is it going to be listening to podcasts and things like that? Especially if you go to a site where maybe you are the only board certified oncology pharmacist there. Like who else can you ask for questions if you're the only BCOP person there that you need help with? So you need to find that community through professional organizations, networking. And if you do go through PGY2, you have those mentors you can call and ask those questions, and you can fall back on that family that you've acquired over the course of residency training. I was telling Brooke before we got on, Sarah, that I was texting when my former students know more than me on different areas. I now can text them and ask them, what would you do with this myeloma patient? What would you do with this? We got this PEDS hemonc question, and I have enough former trainees now that I have a wealth of experience that I can ask for when those questions come up.
I think that also brings up a good point, John, about another advantage of PGY2 is your PGY2 co-residence. If you're at a program that has a lot of co-residence, which usually if you're in onc, you're somewhere that's going to have a lot. So you're going to have critical care, you're going to have, infectious diseases, cards, peds, XYZ. And so I also find that an advantage, even from that standpoint, is getting a network of your co-residents that you trust, that you know well, that you don't feel stupid asking a question to, that you can also reach out to for different things. Like, hey, my patient's in the ICU and XYZ, like, hey, does this make sense to you? Or can you make this make sense to me? Kind of thing too. I think that's a little fringe benefit too.
Yeah, absolutely. All right. Well, thank you both for joining and taking time out of your busy days and your travel schedules to talk to me about PGY2 training. Thank you. Thank you both to Sarah Wheeler and Brooke Adams. And we will have 2 more episodes to follow this one. Any final words, Brooke, Sarah?
Thank you, John.
Thanks all.